we must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Hello, everyone. Welcome to another episode of the Healthcare Education Transformation Podcast. I'm Brandon Pullen, and of course, as always, I'm joined by my fellow co-host, F. Scott Fiel. And before we start today's episode, I'd like to give a personal shout out and thanks to my good friend Brittany Sigelski for telling me about our guests and their podcast, because frankly, if she hadn't, we probably wouldn't be sitting here recording this right now. As today, we are so excited to bring you two very notable occupational therapists who are the hosts of the podcast Glass Half Full Occupational Therapy Talk. And we would like to welcome Jessica Kersey and Natalie Barnes. Now, for those who aren't aware of the Glass Half Full Occupational Therapy Talk podcast, their goal is to provide easily accessible and evidence-based education, contributing to the body of resources available to occupational therapy practitioners and consumers. They strive to demonstrate the distinct value of occupational therapy and inspire listeners to genuinely engage with their profession and help their clients to always see the glass half full. We are thrilled to have the representatives from this essential healthcare profession on the show today, as I know you guys are extremely important, as I worked with some fantastic OTs for the past 2 years at the hospital outpatient facility that I worked at in Michigan. So I thank you guys for coming on today, and welcome to the show.
Thanks for having us.
So Jessica Kersey received a bachelor's degree in health science and a master's degree in occupational therapy from the University of Florida. Since graduation, she's worked in inpatient rehabilitation in San Diego and Las Vegas. She also owned a community-based private practice for individuals with neurological conditions. Jessica is a certified brain injury specialist and has presented at state and national conferences on a variety of professional clinical and research topics. She's recently returned to school in the PhD program in rehabilitation science at the University of Pittsburgh. Jessica strongly believes in the importance of engagement in the OT community and therefore has volunteered her time in a variety of leadership roles for the California and Nevada State Occupational Therapy Associations. She currently lives in Pittsburgh with her husband, Sean.
Awesome. And I'll introduce our other guest today, who is Natalie. And Natalie Barnes received a bachelor's degree in health sciences and concentration in health studies from James Madison University in 2007. And in the fall of 2008, she graduated with a master's of occupational therapy and worked in a school for 1 year before transitioning to acute care. Since 2010, she has worked in the acute hospital setting and inpatient rehab in Delaware, San Antonio, Las Vegas, and now in Washington, D.C. She currently works in the acute care setting at George Washington University Hospital. She believes strongly in the power of occupational therapy and its ability to have an impact on a wide scope of populations and people in all phases of life. She hopes her passion for OT will inspire others to be an advocate in the OT community and our unique perspective to shape the definition of health. And she lives with her husband, Troy, and has 3 young children. Now, ladies, thank you both so much for coming on the show today and for putting your content out there to contribute to making a positive difference. That's not something that's always easy to do. And I realize that we kept both your bios relatively brief, as I'm sure there's a lot more you guys have done. But was there anything that you'd like our listeners to know about you both that we didn't mention in this brief intro here?
And Jessica and I actually met. I guess that would be good information to know. We met working at the hospital in Las Vegas, and I think we're kind of like drawn to each other because of our passion for OT. And so this podcast was kind of born out of that passion that we have, the glass half full.
Hopefully it's clear that we really love OT and our passion for blood orange margaritas and weekly happy hours.
Yes, that too.
Yes. Viva Las Vegas. Perfect meeting place for you two, it sounds like. So for those in other healthcare roles and for those in our audience who do not know, could you both tell our audience what is occupational therapy and what things can an OT do and what settings can they be found in?
Sure. Well, occupational therapy is all about promoting participation in any occupation or activity that's meaningful to the individual across the lifespan. So that is a very broad definition, but that is intentional because we work with people all across the lifespan from birth to, old age. and the needs of those populations can be so different. But really, it's all about whatever is meaningful to the individual, what's going to help them have a better quality of life, better health outcomes, better subjective participation in their lives.
Yeah, it's really all about making sure that they can engage in whatever their roles, routines, and habits are, and making sure that you're seeing them as a whole person and looking at whatever their barriers and deficits are and making sure that they still have access to resources and things that they need to or want to do. And that's so different based on everybody's own situation, home support system, medical, and like health history. So it's a big definition.
We do work in a very wide variety of settings. So everything from schools to hospitals, rehab facilities. That's probably where we overlap with physical therapy the most. But also we work in a lot of community settings. So, God, I'm like losing my train of thought on this word. Like the senior centers to help people age in place. We work in a lot of community-based like cognitive programming, community-based employment support. It's pretty broad where we work.
And there's lots of OTs who specialize in different things. So there's OTs that specialize in like low vision specialties, engagement with driving and being a certified rehabilitation driving specialist. There are hand therapists because a lot of activities that you engage in as far as like meaningful tasks are done with your hands, whether it's to take care of yourself or to engage in a hobby. So there's lots of different specialties as well.
And I think the physical therapists learn about the ICF in school, right? And like the body structures and functions and the activity limitations and participation restrictions. So I think one thing that Natalie and I have in common is that we really strongly value that participation end and certainly some of the activity perspective as well, because there's a lot of overlap sometimes between activity and participation, just depending on what the person finds meaningful. But I think that that's what makes OT a little bit different is we really tend to focus more on that participation end and the subjective, what's most important to the client. One thing I think we haven't mentioned that's really important is our roots in mental health. We started as a profession that worked in a mental health setting. We have this famous quote that we love in OT, that man through the use of his hands can influence their health and well-being, which basically just means that when you do things that are important and meaningful, it's going to lead to better mental health and quality of life. And that's kind of where we got our start with using occupation as an intervention as well as an outcome, specifically in mental health. And we still have a really strong role in mental health, particularly with people with severe mental illness, I think is like a clear example where people struggle with the executive functioning and being able to, figure out how to manage their medications and how are they going to meal prep for the week and make sure that they have enough food and can budget appropriately within a limited income. And I think that's a really nice illustration of kind of how OT is unique.
Yeah, that's awesome. I actually didn't know that you guys were strongly rooted in mental health. Like physical therapy, we were kind of strongly rooted in nursing. It was kind of a nursing field that branched off into like postural stuff and musculoskeletal issues, and that's kind of how we took off. So that's really cool to kind of learn about where you guys really started from.
Yeah. We took off after World War II was when they needed more help with the physical rehabilitation side and physical disabilities, and that's how we kind of ended up moving into that realm, and that's what most of the public knows us for now, those who know of us in the public. But yeah, we started in mental health.
Very interesting. I learned that as well. I didn't know that too. So ladies, I'm going to rewind a little bit and kind of start back from and kind of bring back the memories from when you guys first decided to go into OT. And, what would you guys say are some questions that a potential OT school applicant should ask themselves to see if being an OT is right for them?
So for some reason, this has always stuck out for me. I remember being in OT school that, and I don't actually know, this is based on nothing except for something that a professor said. So it's not statistically relevant about the relationships of OTs and other people. But it always stuck out with me because I've found it to be kind of true, is that a lot of OTs are in relationships who are married, or their partners are like engineers or artists or some kind of creative mind. And I think that's really interesting because OTs are very good because we see patients as individual people, and really focus on like that holistic aspect of care, we're always kind of like creating what is the best way for this person to do this. And again, because it's so individual with their own deficits and their own meaningful tasks that they want to engage in, that a lot of OTs tend to be really creative, collaborative, really wanting to like engage with people, because you really, really have to be willing to kind of jump in with people where they are in their own life and really have a lot of empathy for some person's like individual situation, as well as understanding for just because you think their goal should be something like, well, your goal should be this because you have to do this to go home and be independent. Well, you have to kind of break that down. And if it's more important for them to be able to go home and they want to, read a book or be able to do something with their grandkids, or, they want to play in a playground, that's different than what your goals are, and really being able to have that empathy piece as a potential school applicant and, be creative.
Yeah, I would also echo that the need to have a holistic perspective is really important in OT. It certainly depends on what practice area you're interested in and where you end up going, but OT considers not just like the physical side of disability, but also the psychosocial side. And we do a lot of, the functional implications of cognitive impairments and how do you address those. And I'm sure this is true to a certain extent of physical therapy as well, but we tend to focus so much on the environment. And I think that in OT, we get a lot more of the people with chronic disability, where at this point, maybe you're not necessarily going to make a lot of improvements, but there's still a lot of room to have better quality of life and more participation. And at that point, it's more about modifying the environment and modifying your supports to enable that participation. And I think you really have to have that holistic perspective, understanding, the role of the psychosocial impact and how that can really influence your initiation and your executive functioning, and the interaction of everything is what contributes to outcomes. We have my favorite theory that we learn in occupational therapy school is the person, environment, and occupation model, which is like, it's not just the person's impairments that influence their outcomes. It's also the environment and the task demands, and how can you intervene at any of those three perspectives to be able to influence outcomes in a positive way.
Wow. Yeah, really great takes on that, ladies. Thank you. So let's look at the next phase, right? You've thought it through. You've decided, all right, I'm going to go to OT school. You get accepted. Can you briefly discuss the classes and some of the prerequisites that you had to take in undergrad in preparation for OT school, and then what the OT program application process kind of entailed?
That's probably different from school to school, but most schools, as a basic prerequisite, I think they try and prep you for that mental health portion, because I know that I had like a development and psychology course. You have to take all of the basic sciences, the anatomy, biology. I had to take a health statistics course. I had to take a lot of I'm trying to remember what those courses. Yeah, the human development, but there were 10 different kinds of classes you could take. And I took like epidemiology, like human sexuality, medical terminology. There was, this umbrella of classes that you could take.
Yeah. I know I had a pretty heavy, I know you mentioned psychology, but I had a pretty heavy emphasis on psychology in undergrad. I had a health sciences bachelor, but I had to take at least 3 separate psychology classes. So like general psychology, I think I took abnormal psychology, and like developmental psychology. I know that we had a big background in that, but then also, like Natalie said, the kinesiology kind of classes and the sciences, all that. Yeah.
Yeah, I think that's interesting, because I think a lot of what you guys said, there's definitely some similarity and some crossover between that and PT, especially regards to biomechanics. We had a lot of psychology as well. We had to do nutrition, the bios, chemistry, physics, medical terminology, anatomy. I'm sure there's a couple others too that I forgot, but those are some of the main ones that we had to go through. So I think there's a lot of carryover and some crossover for sure.
Yeah. And then as far as the application process, that's probably different for every school. But I do remember we had a very interesting portion for ours, kind of going back to that therapeutic use of self and how you see yourself as a whole person. But you had to write, they gave you a prompt, and how people chose to express their prompt was like very OT. Like one of the girls made like a newsletter about herself, and someone else sent in almost like those Shutterfly books you can make now. That's more like a photo albums with different stories, or I can't remember what the exact prompt was, but the way that I was like, wow, I don't know if you would see this kind of expression in response to a prompt in the same way that you would for other applications.
So Natalie and I have both been in OT for like 8 to 10 years ish. So our application process is probably like totally obsolete at this point because OT has moved to a centralized application service that's I'm pretty sure it's regulated by AOTA, the American Occupational Therapy Association. But basically it's like a streamlined application program now where like you submit just one application, everybody uses like the same essays and everything now. Like you just upload everything to one service and then you just click on all the schools you want to submit it to, and it's all like the same, standardized across all OT schools now. They all use the same system and the same like essays and everything.
This is literally new information to me.
It's called OTCAS. I don't know what that stands for, but OTCAS. Oh, Centralized Application Service. I just looked it up on Google. Centralized Application Service. But honestly, I have no idea what that looks like. I mean, that was new as of like a few years ago, and I didn't use it, and I don't really know what it looks like. Sorry.
That's interesting because, I mean, actually with PTs too, I mean, when I applied, I've only been out of school for about a little over 2 years now. So we did have to use PTCast, but so it was very similar in terms of a centralized hub. And basically what you did was, depending on the program you would want, you would basically fill out your entire application and submit all your stuff there within the deadline. And then it would be processed and then sent through all the institutions, and then they could review it that way. So it was really a good way to do it. I must admit, my school that I ended up accepting was one of the few that did not do PT casts at that time. I'm not sure if they still have to do that now, or if they're mandated or not. I have no idea about, but I thought it overall was a pretty easily streamlined process to do it. Scott, I don't know if you had to do PT casts when you were going through.
No, back in my day, 11 years ago, we didn't even have that. So it was all individual applications to each school. So I do think it's a much smarter way to go about things. It saves a lot of money, I think, as well. You're not having to pay for every application. So I think it's smart. I think it streamlines it. And nowadays with technology, there's no reason not to.
Yeah, and I think honestly, man, I think it does vary because I do remember if you pay, you get a certain number of applications free to it, but if you wanted above a certain number, I think you had to pay extra per one. I'm not sure what the numbers were on that, but I remember there was something with that. So guys, now kind of going next step into this continuum. So now you guys are in OT school. Do you think you could kind of tell us kind of what were some of the classes that you guys took in OT school and kind of what your clinical education looked like?
No, we talked about this question beforehand. And so one of the things that I had told Jessica about this question that I thought was so interesting, like one of the classes that really stuck out in my mind while I was in OT school is we had a class the first semester in OT school when we were doing kind of like the history of OT and the development and learning more about OT theory. And one of our very first classes that we had was called Therapeutic Use of Self. And I remember in the morning or when we first started the class, I was like, oh my gosh, what is this hippie crap? And then looking back on it, like it was such a valuable class because it was sitting down and it was really kind of learning how to have empathy and talk to each other. And it was a wonderful class. So, I mean, as far as something that kind of sticks out in my mind as kind of maybe more unusual, just a very valuable class.
So for me, like I went to University of Florida for my OT program, and now I'm at Pitt and I'm on like sort of more of the faculty side, I guess. So I get to see what goes into a lot of the curriculum development and design, even though I'm not like in that OT program. But it's a completely different structure. And so I think it's interesting now comparing that. But when I was in OT school, we basically had like our intro semester where we learned about like research methods, foundations of OT, like basic OT theories. And then we had like some psychosocial stuff for a few classes. And then it was just like the rest of the time was Florida structured it in a really neat way where it was just fall was everything adults and spring was everything pediatrics. And we went through all of assessment and intervention for like the variety of the conditions that you'll see in each of those populations. And it was nice because it gave us a lot of flexibility to cover the wide range of conditions without having to fall under, a neuro rehab class and an orthopedics class and all of that. Like we could just kind of go as it made sense. Whereas Pitt has a lot more structure, and when they cover, like they'll cover general clinical skills, things like activity analysis and, like therapeutic use of self. And those are all like different classes. Hand therapy is a different class. So it's very different looking at Pitt's curriculum versus what I did. But certainly some of the things that were most heavily emphasized was, activity analysis is such a theme in occupational therapy because, like I mentioned before, we do work with a lot of people on the more chronic side where it's more about compensatory strategies and modifications of tasks and environments more than remediation. And so figuring out how to really analyze a task to figure out where the breakdown is and the person's successful performance of that task and how you can adjust for that. And also how to grade activities to make them the just right challenge for that person. So those are the two kind of takes that we took on activity analysis. And that was a very strong and consistent theme through all of our classes.
And I do think that there's so much hands-on learning that goes on that I'm sure I feel like it's kind of like that for any medical course. But when I was in school, we had a lab. We had like an ADL suite kind of lab for more like hands-on learning and practice for things when you're learning about like mobility and toileting and how to FIM this or assess this different deficit. And our classroom, I remember when other schools would walk by our specific classroom, because we had kind of a section of the upstairs area, and our actual classroom, because we had a learning lab and we had a classroom, and our classroom always to me, and even to anybody else who walked by, looked like a combination of a peds gym and like an adults outpatient clinic. And so as far as the hands-on learning piece of being in OT school, it's huge. Neurolab is so interesting when you're doing like vision screening and proprioception screening. And I remember people would walk by and, they had to be thinking, what are they doing in there? So I think going to OT school and kind of looking at it from an outside perspective would be very interesting.
So just kind of a follow-up to that, you guys, it was a 2-year master's program, right? And are they looking to transition that into a doctoral program for OT?
Yes.
And now you mentioned that you had to do a lot of hands-on in labs. Did you also go out and have to do clinical rotations where you were sent into a clinical setting and had to learn for a couple weeks there as well?
Yes. And I think that because we had level 1 fieldworks and then level 2s, and I think that the way that schools do level 1 fieldworks is very variable, because when I was in school, I did like 3 separate semesters, and every day, like 1 day a week was like a level 1. We didn't have class. So like every Tuesday for the whole semester, I went to like a Head Start program at a school, or somebody went to an outpatient clinic for hands or wherever. Everybody went somewhere different. And then at the end of our clinical rotations, we went out on 2 12-week level 2 fieldworks. But I know that the way that different schools do that differently, because like I have students that come and observe now, and they do 3 separate level 1 fieldwork observations that are all like 1 week long. So they spend like 1 week, 40-hour week immersion. Yeah, but the school, yeah. So anyway, I know that there's different ways of doing that. And Jessica and I have talked about that a lot of schools are moving towards a more simulated level 1 learning experience, which I think there are pros and cons to both. Yeah, different ways of doing things.
And I think that's really only happening because we have such a shortage of therapists willing to accept students. It's very sad. But we still do have 2 level 2 fieldworks, which are 12 weeks each. And as we're moving to OTD programs, they tend to have, I think, an additional fieldwork that's 16 weeks as a third fieldwork.
Yeah, that sounds pretty intense. So just like physical therapists, occupational therapists have to pass a licensing exam, which for OTs is the NBCOT. What would you both recommend for students preparing for that exam in order to kind of get ready for it and try to pass it on their first try?
Well, I took NBCOT offers like a review course. I actually went to a weekend course very similar to collecting like continuing education or contact hours. So I went to one of those courses that was like a weekend long course, because I am a terrible test taker. I'm someone who is very good at like talking myself out of the correct answer because it's either not detailed enough or it didn't take into account the amount of client factors that I think that it should have. So I actually went to a course to help with that, and I did find it helpful. So
to be honest, I hardly remember anything from my NBCOT exam. I remember that we had clinical cases, which were kind of interesting because like they're multi-step. So like you are presented with a case and the first question is about like what would your approach to assessment be? And then based on your response, it gives you like, well, then this is the results of that assessment, and then what would you do? And it like walks you through a case and you have to respond, and it gives you more answer choices based on how you respond. And I know the one thing I do remember is that I intentionally took my exam on the sooner end because I wanted to kind of like dedicate myself. It was very nice the way they had it set up. Florida, we graduated and we had field work in the summer and then the fall, but then we ended like almost a full month in advance of the actual graduation date. So I just made sure to like use that time and like just study. I just studied for that whole time and just took it right away before I started a job. I know a lot of people will take a job and start working before they actually take the exam, which seems to me like it'd be a lot harder when you're trying to study and also manage your first ever full-time job as a therapist when like that's very stressful. And how can you manage studying at the same time? Some people I'm sure can do it. That just wasn't like my style. So I just dedicated myself to studying full-time until I took the exam and then started my job. So I don't know, probably is variable based on individual learning preferences, but that's what worked for me.
yeah, I didn't live in a state that you could do that. Like you had to have your license to work, because I know that some states you can get like a temporary license. Yes, a provisional license. I didn't live somewhere you could do that. So
Very interesting. Interesting. And it's interesting to hear kind of how that test is structured actually. So I guess I'm kind of curious now. Since it's kind of build off each other, if you didn't get one part of the early questions right, does that mean you were done for the next set of questions, or did it reset with something different? Or
It doesn't mean that you got, anything wrong. It just then it gives you like certain information, and then you need to hopefully make a better decision based on the information that they give you. So you can continue to proceed through the case. Just, keep going.
I'm picturing that horrible thing when you're taking the CPR test, like when you do the simulated one online and you're like, okay, they're still doing CPR and nothing's happening. They've been doing CPR for 30 seconds. I must have missed a step.
I know, ladies, you guys kind of said some of these answers to my next question earlier on, with both of you guys being practicing clinicians and kind of looking back on your OT education, what would you both say are some of the biggest strengths that you've gotten from school that have helped you the most with transitioning to be a clinician? And perhaps some of the avenues that perhaps you guys didn't talk about earlier.
Okay, so this is what I would say. So I remember being an OT student, and we would talk so much about theory in every class. We would review theory, and I remember feeling like I am not learning the actual skills that I need to be a competent therapist. And when I show up on my first day of field work, I'm going to have no idea what to actually do because all I'm learning is theory. And I remember being really frustrated by that as an OT student. But then after like my first year or two as a clinician, it finally like dawned on me how much the theory was guiding my treatment planning and my assessment approaches. And if I didn't have that theoretical background, regardless of how many techniques they would have taught me in school, I wouldn't know what to do with them because that theory is so essential in guiding your treatment planning. And I would just say, like, to any student that's listening, if you're frustrated by the amount of theory that you're being presented with and you feel like it's a waste of time, like, it's not. It's definitely not a waste of time, and you need it, and just power through. It's important.
I'll play devil's advocate a little bit then, and we'll say, what would you guys say are some of the biggest limitations of OT school, looking back at it from where you both are standing now as clinicians?
One of the things that I don't think that they prepare you for as well as a clinician, and I think this is probably standard things like across the board for anyone working in the medical field or even as a therapist, is even now, I've been out of school for 10 years and I still struggle with time management. I always feel like I can spend so much more time with a patient, and there are so many things that I want to do or talk to them about or educate patients about. And there's a certain time where you have to say, okay, that's enough for one day. And I struggle a lot with time management. Another thing that I really struggle with, and Jessica and I have had conversations about this before, and we just released an episode about it, is I still don't feel prepared enough to be efficient and find research articles for like interventions that I would like to do at work that are effective, and how to find like good research, use good keywords, access to like search criteria. And it's been a struggle for me ever since I came out of school, is finding resources that like translate and generalize into general practice. It's been a struggle.
I have a pretty different response. For me, I think one of the things that I wish would have been emphasized more in my program is how to be a good advocate for my patients and also for my profession. Having worked in inpatient rehab, and I know it's even worse in a lot of skilled nursing facilities and also outpatient clinics where we're pushed into this box of like, see these 3 patients at the same time or overlap these people by 15 minutes and like have 100% productivity and like all this nonsense that's not reasonable if you're wanting to provide good care. Like all these real life barriers to providing the care that we want to be able to provide, that level of quality that we want, that's all driven by administrative decisions and administrators who are not necessarily working in the trenches. I wish I would have been better prepared for advocating for that. And I did eventually get to the point where I was comfortable pushing back when the situation called for it. And I eventually opened my own practice so that I could provide the kind of care I wanted. And then that put me into a whole new challenge with advocacy because I needed to market to doctors and to medical assistants and, you know, wide healthcare insurance companies, like all sorts of different people who didn't even really necessarily know what OT was or what our role was for their patient population. And it's a learning curve. And I feel like that's a really important skill, especially considering how healthcare is just getting more and more expensive and insurance companies are pushing back more and more on what we can do. And unless we can provide like the right kind of care, the right quality level, we're not going to get the outcomes that we would get otherwise. And being able to demonstrate that, I think, is a really important skill that is going to be more and more important as time goes on.
I just want to give you a big standing ovation, Jessica. That was a great answer. I'm clapping over here. Good work.
Absolutely. Advocacy is so important for all of healthcare. I mean, it doesn't matter what field you're in. I actually am in the state of Texas, and we currently don't have direct access. We're one of the 3 states in the country that doesn't have direct access for physical therapy. So we still need a physician's script to treat, which is insane to me, but it's ridiculous. But beside that point, advocacy in any way, shape, or form is just so important. And Jessica, to your point, I think that a lot of the PT programs, at least that we're seeing, are starting to incorporate it more and more in the doctorate students. And then speaking of the DPT, I was a master's in physical therapy and then got my transitional doctorate eventually. So Natalie, I will say this to your point, a lot of these DPT students are coming out with a great knowledge base on evidence-based practice and how to find a lot of that research that's out there. So I'm using the younger students to get my research and to guide me, you know, as far as how to get the articles and how to be pretty efficient about it. That's been one of my links. Younger crowd that's coming out. They seem to have a real good grasp on it.
Yeah, and that's 2 really good points. Like, first of all, the value of taking students. You get to have access to articles and resources and new knowledge that you wouldn't necessarily have. But I think that those 2 things are like some of the biggest benefits OT is transitioning now to the OTD, the clinical doctorate, as the entry-level degree. And a lot of programs have already transitioned to that. And I do think that that's one of the benefits is you have more time to develop skills for research, and you have like interpreting research, and you have more time to develop the advocacy. And based on several of the programs that I've seen, including Pitt, that have already transferred to the OTD, they do their 2 level 2 fieldworks, the 12-week fieldworks, then come back for their 3rd year of school and then go back for their final fieldwork. And I feel like having that experience is probably the best way to be able to teach those advocacy skills. Like, think of the time when your patient, like, you couldn't see them one-on-one the way you wanted to because they were in like an exercise group or like something they didn't really need because that was an administrative decision, or, problem solve through those examples that you saw in real life. I think those are two of the benefits that I'm hoping we see with the transition to the OTD.
Yeah, for sure. And I think even for our program, with me going through the DPT, I think it was interesting because we did half our clinicals before our last year, and then we had another semester where we kind of had a good kind of integration semester, and we learned some other stuff. And it was so much more impactful. You go back in school and you're like, now I know how to, the environment where I'm going to be applying this in, but now I can take this in and better apply it and think about how I'm going to apply it in that setting now. Where before I kind of felt like I was this blank slate. So I think that's definitely been a certain pro. And I think some of the issues that you guys brought up with advocacy are extremely important, especially particularly right now with the Medicare cap and with Congress not acting and now the government being down. Like, that's just absolutely mind blowing to me. And, I'm really shocked that that's happening. But besides that.
But again, I feel like that kind of plays, unfortunately, to so I live in DC, and, going up to Capitol Hill and having access to, March the Hill Day that they do in September for OT. And it's been interesting that there's so many people, they don't understand the distinct value that like OT or PT can bring to a patient's quality of life, or, training families so that people can stay home longer and reduce some of those healthcare costs is a huge, huge barrier and opportunity. So when you talk about some of those issues, it's unfortunate. And it's because they don't understand the distinct value that we can bring with the therapy caps. And, they're only looking at the medical side of things, unfortunately. And there's so much value that we bring in other areas that we can expand into.
Holla at that. And so, I kind of, you guys are just going at this question. So I guess I should formally ask it now. But, what are some of the biggest issues that are currently facing the OT profession?
Yeah, certainly administrative and legislative barriers are some of our biggest ones. And I think another one, I have a passion for community integration. And I'm back at school now pursuing a research degree, and my research focus is facilitating community integration and participation for people who've had a brain injury. And I just feel like for so many of our patients who have especially cognitive impairments, like, the environment is so important. And I think that we do a really good job of considering environmental factors in the strategies that we teach to people, especially like in an inpatient setting and you're focused on getting people home. And I think we do a pretty good job of considering, like, what do you have steps to get into your house, and like, what's your bathroom set up and all of those things. But I feel like one area where we miss the boat a lot of times is, like, we can talk about those factors all day, but not being in like a naturalistic setting. Especially for people with cognitive impairments, it's so much less likely to translate and generalize. And I think of even like when this became really obvious to me was like, but even like simple things. Like, I remember one time in inpatient rehab, I had a patient who had pretty severe ideational apraxia. So like when it came time to brush his teeth, would try to stick his toothbrush in his ear, or like try to shave his face with his toothbrush instead of using it to brush his teeth. And like we went through like the repetitive task training. He finally figured it out, got to the point where he didn't need cues and could just pick up his toothbrush and brush his teeth in his bathroom in his room. But as soon as we went, say, like, if we were in the shower room and he took a shower and then like tried to brush his teeth in the shower room and it was a different setup and things were in a different place, suddenly he had no idea what to do again. And just because they learn a skill doesn't mean it's going to generalize to other settings. And so I feel like one thing we're really limited on is the ability to practice in a naturalistic setting. And with my practice, it was a community-based practice. So we would do evals in the home, but then deliver intervention, like sometimes in the home or sometimes like at the grocery store or at the mall or wherever they were doing their actual activities. And I struggled with reimbursement because there was no like model within Medicare to reimburse that kind of service. And we ended up having to bill under outpatient services. And the only way the outpatient clinics stay afloat is by overlapping their patients. and wanting to deliver one-on-one community-based care, like my business would never have stayed afloat. Like I needed to close it down anyways in order to come back to school, but I would have had to drastically change my practice to be able to stay afloat financially. And I just think it's really frustrating that like we're totally missing the boat on one of the most important factors in whether a person's going to be successful. And that's a limitation again of reimbursement structure and policy. And I don't know, I feel like that's a really important consideration, and that should be a really easy thing to do, deliver services in a naturalistic setting, and we can't.
Yeah, no, I think that's a really great take. And I think there's a lot of parallels with that with physical therapy as well, because I know, at least from a lot of people that we know too, that a lot of people, I think there's a lot more people that are becoming more aware that we need to do more community integration. But I think a lot of them, frankly, are really afraid to step out of that box and take the risk because they're not going to get reimbursed for that. And they're not sure if they can pull it off, that they can survive financially. And at least I can tell that's from a lot of our profession too. I mean, that's a big thing, especially with, with Medicare making cuts, and then it's only a matter of time before other insurances are going to follow suit. It's like, we can't keep doing it this way. This is not going to solve the problem this way.
So one of the other issues that Jess and I have talked about on our podcast is how, as a profession, and this is related a little bit to the advocacy portion we were talking about, as well as the way that we implement interventions in our own practice, is that OTs need to move away from billing and using therapeutic exercise as like a fallback for doing more creative, one-on-one, meaningful and purposeful, like skilled interventions with our clients, because it's been proven over and over again that sometimes, as Jess touched on earlier as well, when you are doing either like cluster or group repetitive training, they don't generalize into everyday tasks that we're trying to do at home. And so the more functional activities and things that we can do with our clients, so that those movements, like, when you're talking about, well, we need to work on strengthening their arms. Well, what kind of functional activities can you do to do that will translate, and that they will remember that they did, or feel more confident in being able to do at their time of discharge, because those are things that we've been working on in the clinic, and making those things really meaningful for those patients. Because lifting up a bar over and over again isn't going to translate as well as, knowing that they have to go home and do certain things either with their kids, or if they like to cook, or different responsibilities that they have. And so that's another thing, is that we think that people aren't seeing the value of OT as much because they don't really know what they're getting. And that's an us problem. We need to be better. It's an us problem. We need to really, so when we talk about like big issues, we don't think that a lot of people know what OT is and the value of OT because of us. Because we are not doing what we should be good at, and really doing activity analysis, breaking things down so that clients can do functional activities.
Well, and it's a branding program. It's a branding problem too. If we can't come to a consensus amongst our own profession, what it is that we do and provide, how are we expected to parlay that to the public so that they understand what it is we do and provide? It's a problem that's been going on for a while now, and until we really come together and start showing our value to the public, they're not going to know what we do.
So I think it's hard. I think it is an us problem. I think we have to get better at advocating better for it in many different aspects, because the way it's stacked against us right now, I don't see it changing.
Yeah, same. Agreed. And I think it's really easy to blame administrative policies, even though I've kind of done that tonight. It is easy to blame administrative policies for like, I have to meet this productivity expectation, and so I'm just going to give this person this exercise while I run over here, and then give this person this exercise, and then run back and go back and forth. But ultimately, like, it's up to us to be more creative about how we use that time that we're given, and find a way to, in the case of OT, I don't know about PT, but in the case of OT, maybe do like a cooking group, and figuring out how you're going to access like low cabinets when you have hip precautions or back precautions, or how you're going to get down heavy plates from overhead when you have hemiparesis and one of your arms. And together you can kind of problem solve that with other people, and there's creative ways to work around some of those barriers, and we need to be better about initiating that and not just taking the easy way out.
And this kind of relates back to that whole administration rules. Well, and this kind of goes back to that thing I was talking about at the beginning, where when you said what kind of people should go to OT school, it kind of goes back to what we're talking about now with having that kind of creative bone in your body where you're willing to kind of step out there and do something a little more unconventional because it's better for your clients.
Yeah, no, I think that's absolute gold. And ladies, what would you guys say, to switch topics here just a little bit, just because I'm curious on this one aspect here, with us being kind of more of an education-based podcast, what would you guys say were characteristics of some of the best educators that you had the pleasure of learning from?
My favorite people to learn from are honestly people who are just passionate about what they do. I find that those people just draw people to them. Like if they, have passion for what they do and they always, are advocating for their patients, want to do what's best for their patients, the right thing and the best thing isn't always the easy thing. And I am always drawn to people who are doing unconventional things and have passion projects. And I mean, really, yeah, that's it. That's an easy one for me.
Yeah, that's a great point. I think, clinical reasoning skills show you to do that and to take that plunge. So I definitely think you guys are on the right track there. Ladies, thank you both so much for your insight on the realm of occupational therapy, as it's been very enlightening to hear. I know we love working with you guys. We love learning from you. So, we like to end each episode with this question. And granted, this may or may not be discussed a little bit, earlier in the episode, but if you could change one aspect of healthcare education, OT or other healthcare provider related, which aspect would you change and how would you go about changing it?
So I feel like in both OT and PT, I feel like there's so much gray area when it comes to approaches. Like there's not always, this is the best approach for this patient and this is the best approach for this patient. It's not always clear how to proceed, and there can be many possible ways to proceed that are all okay. There's a lot of gray area, and I feel like in general, therapists a lot of times tend to be people who are kind of type A and kind of black and white, and feel like the best educators are the ones who can help like us type A people just embrace that gray area and understand that there's not always a clear answer, and you can just try an approach, and if it doesn't appear to be working, try a different approach and be okay with that and confident with it, and not let it like ruin your self-confidence and ruin like your love for what you're doing.
I know what I want to say, but I feel like there might be like a better answer. Like I went with in my head, I want to go with my first gut instinct because I want to go with what my gut instinct was, but I know that it's like not reasonable and it's not doable. It's like the dream. Okay, so the utopian answer for me, and I say it at work probably once a week, like I love my job so much. And I know that productivity is what productivity is, but even beyond that, the productivity standard really inhibits, and it's really the documentation. Like, because I feel like in a day, I could see so many more patients and help so many more people, but if documentation just wasn't a thing, like if it just wasn't as intensive, and I know that there are rules and there are regulations, like I know it's utopian, but I could see twice as many patients in a day if I didn't have to document everything that I did.
Yeah, I'm glad that you said that, because I'm going to pose an idea. And the reason that we do this podcast is for exactly that. We're looking for bigger thoughts, bigger 30,000 foot views, people who aren't afraid to push the envelope a little. And I'm going to tell you about a story that is constantly being brought up here. And actually, Brandon and I know and have had a guest on that is working on a solution possibly to your problem. Rob Vining, he is one of the hosts of PT Tech Talk, and he is thinking about working on a program, and there's some others that are involved in this and some others that are thinking on doing this as well, where we have almost like, the Google glasses that you wear, or they had brought those out for a little while, and it's almost like we'll call it a virtual recording, or better yet, even like Snapchaticals, okay? Where you go in to treat your patient, you're wearing these glasses, and it records the entire treatment session, and that is your documentation.
And I hear that, but so I have a lot of issues with that, actually. Yeah, there's and my issue with that would be like I love the idea of that, but one of like the foundations of occupational therapy is your ability to do activity analysis, break down a task and talk about the barriers, limitations, change different whether it be like the person, the environment, the task that they're doing, like really honing in on activity analysis and being able to change that. And that's not something that because we're a skilled service that the average layperson or someone doing a Medicare chart audit is going to know like, well, I moved this farther away or I added this to this thing because I'm trying to address this barrier or this deficit. Like that's not something that Google Glasses would pick up. See, but with people with cognitive deficits, you couldn't do that because a lot of times you're trying to look at that cognitive piece, which is the problem solving, insight into their own deficits. No, that's an interesting thought for sure.
So I'll say this, like being somebody who really loves cognitive rehab and the cognitive side of like brain injury, I don't really love that approach because there's so much about like minimizing how much you influence the patient's response and all of that. But that's a whole nother thing. But one thing that I do appreciate about that approach, though, is that that's really innovative. And that's, I think, one thing that I would say in response to your question about, how would you change OT or how would you change education, healthcare education? And I feel like we've talked a lot about advocacy tonight, but also leadership, I think, is very distinct from advocacy. And I think that we need to be trained a little bit more on how to be good leaders within our field and, take risks like trying new innovative ideas, even if they fail, doing something to try to improve the way that we approach some of these difficult barriers that we face in day-to-day clinical practice. I know I had a leadership class in OT school or maybe leading up to OT school or something. And it was just like a review of these are some of the leadership approaches that are currently taken and here, take this personality test. And it wasn't really teaching me how to be a leader within my field. And I feel like that's a really important skill that is needed to be innovative and creative and being a change agent, to be a change agent within our field to make positive changes.
Yeah, I think those are some great points by everyone on that, as I think that's definitely, all those things are definitely going to contribute to these problems in some way. And I think those are some great discussions, some things that you guys are going there. And ladies, kind of before we kind of wrap up here, where can people find you both online and on social media?
We have a website. You can find us at www.glasshalfffullot.com. We have a Facebook page. You can also find us on LinkedIn.
All right. Well, awesome, ladies. Well, again, thank you both so much for your time coming on to speak some really good stuff tonight. I think it was definitely some valuable stuff that was discussed, and I hope this can be very valuable to kind of both our listeners and as well as any healthcare provider or any healthcare student for that matter as well, to kind of really open up to kind of see it from a different lens and get a different professions' opinions and kind of perspective on things, because I think the main way we're going to help this problem is if we collaborate together, and there's nothing more enriching, in my opinion, that kind of this interdisciplinary collaboration, because I think we can all learn so much from each other. So thank you both so much for your time and everything. And, it's always a pleasure.
Yeah. Thank you so much for having us on. This has been fun.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.